Dear colleagues, ladies and gentlemen, it's a great pleasure for me to welcome you to Dentsply Sirona's webinar and live stream with the integrated implantology. My name is Frank Zestra. I'm dentist and oral surgeon, and I will guide you today through the surgery. On my side is my colleague, Dr. Gerhard Werling. We are here in the southern part of Germany, and he is experienced implantologist. He placed thousands of implants in the last 25 years. And yeah, Gerhard, it's nice to be here. And can you tell us something about the case and the patient?
Hello Frank, thank you for your introduction. Yeah, the case is a 34-year-old lady, and she had some problems with her endodontic treated teeth, and they have to be extracted. So this was another practice, and they also make a socket preservation in this case.
Mm-hmm. Okay, and how did you prepare on this case to this surgery?
So today the topic is digital workflow. So I want to show you just a few pics that we did for this. We have the CEREC Omnicam, and we make an intraoral scan by Nadine, and we just look at the screen, and you see the tooth number 25 and 26 are missing. So what we do in this case, we make a proposal from the software, and then we plan the prosthetic. Yes? So Melanie, could you just click into the picture where we see the prosthetic planning? So these is a prosthetic planning because we want to do a backward planning. And we go directly with this data, we export these data from the CEREC software into the Galileo's implant software. So maybe look at this screen over here, and you see here already, just a second. This is the cone beam from Nadine, and you see we already planned 2 implants over here. And now we can superimpose, after we match these data with our CEREC data, and you see exactly the model, and you see the prosthetic planning that's coming from our CEREC software. And you see also here the gingiva thickness, so this is really cool for you for your planning for your surgery.
Mm-hmm. Okay, interesting. What exactly are you going to do today?
So with this data, we got on the digital way the possibility to get a drilling guide from the company SICAT, and this we are using today to insert the 2 implants. The 2 implants will be Xive implants, 3.8, 11 millimeter, as you see it over here, and 4.5, 9.5 millimeters.
Okay, very good. So, I wish you all the best for the surgery, and we will talk again after the surgery. And dear colleagues, please feel free to get in contact with us via live stream chat or via Facebook, or you can also write us an email if you have any questions to livestream@dentsply-sirona.com, and we will answer your questions right after the operation. Okay, see you then. So, okay. So, dear colleagues, what you're seeing now is the X-ray, the Galileo's implant software, and the backward planning. Like Dr. Werling said before, in this case we prepared an OptiGuide drilling template, and this was manufactured entirely from the digital data collected before.
Ihr könnt schon ein Bild kommen.
So, I think now we see the operation room again, and we will go directly into the operation. Local anesthesia was given 10 minutes before, so this is really live what you see now. Okay, we try to zoom into the area 2.5 and 2.6. Into the maxilla, left maxilla. Okay, great. So socket preservation was performed 4 months ago in this area with the allogenic bone. We do some crestal incision. I don't want to bore you with too many studies, but a very interesting study from Kleinheinz 2001 showed that incision in the crestal, middle of the crest is preferable because we keep the blood supply, because the blood vessels meet in the middle of the crest. We try to avoid relieving incisions, also to keep the full blood supply. So the plan was to do a minimal invasive treatment, and that's why we were planning the case before. Because also when you do socket preservation, what was performed 4 months ago, we don't know if we have some bone loss in that area. Another study from Fickel and Zur 2007 showed that socket preservation with bone substitutes showed slightly better results in comparison to avoiding socket preservation. But anyway, in many cases we can't avoid totally to have some loss of bone because of loss of the bundle bone. And this is the reason why it's preferable to have a CBCT before, a three-dimensional picture before, to do some backward planning, to see do we have some bone resorption or not. And in this case the CBCT was performed with Galileos, and we did the backward planning in the Galileos implant X-ray software, also to see critical anatomical structures in the CBCT before the operation. And here you see the use of the OptiGuide. The OptiGuide is in comparison to the classic guide. Let's say that the data are collected complete digitally. So the OptiGuide drilling template was chosen and manufactured entirely from the digital data collected before. These data from the CBCT were matched with the intraoral scan we got from the OmniCam scan before. So a fully digital process. That means also a gain of time, reduced time. We don't need to deliver models by post. And the planning of the implant surgery is done intuitively before with a few clicks in advance to plan precisely the exact position, angle and depth of the implants. And here you see the first drill. We are starting, or we want to place Xive implants. And this is a sleeve-to-sleeve system. The idea is now to do some center punch with a full diameter drill first. So just to tip with the drill to center punch the right position. And Now we switch to the pilot drill. After center punching, we switch to the pilot drilling. Diameter 2 millimeters now. So I remind you, the full diameter we were planned was 3.8 millimeter Xive S implant. So first center punch and then pilot drill with the 8 millimeter burr. The planned diameter is 3.8 and the length of the implant is planned 11 millimeters. Without any bone augmentation, any sinus floor elevation, we have enough bone. So area 2.5 we are planning 11 millimeter length. Area 2.6 we are planning a 9.5 millimeter length. But we know from many studies, such as from Weigel 2010, that also shorter implants than with less than 10 millimeters show similar results to longer implants, so we don't need a 15 millimeter implant here. The distance between the two implants should be not below 3 millimeters. We know this from studies from Tano, very famous studies that show that the distance between two implants should not be below 3 millimeters, and from implant to tooth not less than 1.5 to 2 millimeters. So after the pilot drilling, we will change to expansion drilling. So, but this is still the pilot drilling with 2 millimeter diameter. This was length 11 millimeter. All these guided through the sleeve-in-sleeve system. This makes it very easy, very fast, reduced operation time, which prefers or which leads to a better wound healing. The shorter the operation time, the better is the wound healing. You see now that was the expansion drill with 3 millimeter. So the twist drills, we call it Xive twist drills, are used in an ascending order until we reach the planned diameter from 3.8. So this is the 3.4 millimeter diameter. So we go in an ascending order through the sizes. We have different colors. So the last color will be yellow, which means, you see here now, which means 3.8 millimeters diameter. You can change the drill protocol slightly intraoperatively when you see the bone density is maybe less or more. So we have 4 bone qualities from D1 to D4. And here you see the Xive Crestal twist drill for the crestal preparation. So it's not general anesthesia like you saw before, it's local anesthesia. And it takes more time for diagnosis or for preparation maybe when we are using a surgical drilling guide, but the operation will be much more faster, so reduced operation time for the patient. Okay, 2.5 is finished, so we are ready for placing the implant. Now we go to area 2.6. starting with the pilot drill again, which was a diameter of 2 millimeter. The recommended speed of all Xive twist drills is 800 rounds per minute on average. And in the background you see the laser and the Galileo's implant software. So again, the pilot drill. In the background you saw the zero laser blue. We can use this laser for many indications, either for cutting or for hemostasis or for biostimulation and reduction of bacteria. So the next diameter is, after the pilot drill of 2 millimeter, is now the next twist drill with diameter of 3 millimeters. Now 3.4 millimeters, you see it at the gray color of the drill. In the maxilla, in most cases we have less density than in the mandible, so the bone is a little bit weaker. For this we need an implant design which gives us a good primary stability, like Xive. Xive has a very interesting design. On one side, in the crestal area, it has a condensing thread section, and in the apical area, self-tapping progressive threads. I will go more closely in this, but let's go back to the drill protocol. That was the countersink, or let's say the Xive crestal twist drill with the last diameter. Oh, sorry, not the last diameter. Now comes the last diameter. You see blue. Here we are planning not a 3.8, we are planning a 4.5 millimeter Xive implant. So we can remove the OptiGuide. The OptiGuide drilling template, we can get it by a fully digital workflow, so we don't need a radiographic template before. So everything, the whole workflow is fully digitally. The limitations with the SICAT OptiGuide are fully edentulous jaw, so it's recommended to have a partially edentulous jaw, like here. And it's an advantage when we have minor metal artifacts. If we have lots of metal artifacts, we recommend better the classic guide. So the accuracy, or it's very the template from OptiGuide is very accurate. We get a certificate of accuracy. It's guaranteed to be within 0.5 millimeter accuracy. So that gives us high comfort and high security by placing the implants, especially when we have anatomic structures in this area, in the mandible, the nerve, in the maxilla, the sinus. And with the template comes also a drill report. So it's very easy to handle. And now we are ready to place the implants. What we did now was just nivelating the bone level a little bit, because we had some disturbing, a small part of bone, disturbing part. And you see here the use of the blister, or how we take the implant out of the blister. So it's a double blister system, it's a shuttle. And now we can use the implant driver. You can do it either manually, like you see it here, or you can also use a contra-angled handpiece with or without torque control. It's on you. So the implant with the FreeAdent temp base is now placed in the cavity through the template. And now he is switching to the ratchet to give some torque control. The speed when placing implants must not exceed 15 rounds per minute to prevent heat necrosis. Slowly the implant is screwed to its final position. And you see small dots at the implant driver. Each dot, or 6 dots, are milled in a circle on the Xive implant driver for implants, and each dot indicates the center of a face of the internal hexagon. And at the end, 1 dot on the implant driver for implants must point in the vestibular direction in the end position. Okay, we have the final position now of the first implant. And you see how the assistant is preparing the next blister. She is opening the blister, and Dr. Werling can take the implant out of the shuttle. And now we are placing the 3.8 millimeter implant. Okay. And we are placing the 3.8 millimeter implant into the final position, changing to the ratchet again. So when we are planning the implant, we can see the perfect angle before. Regarding a backward planning, we can plan the exactly position, the depth. But what we don't see in the CBCT is the bone density. Like I said before, it really depends on the bone density. If we can do abutment, one time concept, that means that we place an abutment after this. We have prepared the abutment already before, or if we say we prefer submerged healing, so that we close. It all depends on the primary stability. So we will see now which operation Dr. Werling will choose. It really depends on the primary stability. If we can place a provisional abutment immediately, or if we will suture it, cover it and do submerged healing and place the crown after 2 to 3 months. So that was really a fast implantation. So the wish of the patient was to get a minimally invasive procedure, and on the same time operation with the highest level of safety. What you see on the implant is the temp base. So we are removing the Friadent temp base now with a screwdriver, 0.9 millimeter. So we were able to place the implants in the exactly right position in the jaw with the aid of the OptiGuide drilling template, fully digitally workflow. The Xive surface favors stable adhesion of bone-forming cells. The apical area of the Xive S is self-tapping, usually gives a good primary stability, but again, it depends on the density of the bone. If we are able to do immediate loading. So around the implant, studies from Krunda, around the implant 2 millimeters of bone are recommended to avoid bone resorption. But that was planned already in advance with a CBCT scan according to the backward planning concept. We are placing now the cover screws. That means it is not enough primary stability for immediate loading concept. So though we have prepared the abutments on tie base, we can use them later, but we will go the secure way, the safe way, by do a submerged healing. That means the cover screws are fixed on the implants and we will suture the flap. You see, we could avoid relieving incisions, which gives us better blood supply, better healing, less trauma for the patient. So probably almost none swelling, or maybe a little swelling.
Ja, Messer wird gemacht. Wenn zugenäht ist, komplett Lisa.
So we are suturing now.
Schwer. Hast du noch eine zweite, ne?
So for better healing, it is possible to use the laser, the Zero Blue laser. Let's see if Dr. Werling will use it. Okay, this is real life like it is. It's though we had prepared the abutments on tie base, we can't influence all components of such an operation. In this case, it's more important to get a predictable result, and if the primary stability of the implant is not given, we have to go the safe way. First, submerged healing, give the healing the time, 2 to 3 months, and then place the anemic hybrid ceramic crown. So the implants were inserted in exactly the right position in the jaw, like we planned before. In the right position, in the right height, in the right distance between the implants and between tooth and implant. After the operation, we will do some X-ray. In case we had enough primary stability, we could have placed the tie base anemic abutment immediately, the mesostructure. Do another scan with the Omnicam and place a provisional crown on it for immediate loading. But anyway, with a reduced height of the crowns. No fully loading, only no contact. But in this case, we have always this, let's say, risk that we have a weak bone quality, especially in the maxilla, D3 or D4 quality. And in that case, we have to keep in mind that the socket preservation was done 3 to 4 months ago, alio loco, so it was in another clinic with the allogenic bone, and So this may be a reason why we have no full osseointegrated bone substitutes. This can happen. It depends on the regeneration potential of the patient. So each experienced surgeon knows that when we are working with the bone substitutes, it depends on the regeneration potential of the patient if we have a full osseointegration or only a partial disintegration of the augmented bone substitutes. This may also have been influenced this case. So no relieving incision means also that we have a reduced operation time. We can suture it faster, only on the crestal area. So this was a minimal invasive implantation. With no sinus grafting, no bone augmentation, because we used the residual bone. We could see this by backward planning on the base of a CBCT matched with Omnicam scan. And I think this is the future, to maybe spend more time in planning, but to have a reduced operation time, which is good for the patient and gives a better result, healing result. And I said before, we were placing a 11 millimeter implant and a 9.5 millimeter implant. Even recent studies show that the implants with even smaller length are showing similar results to longer implants, also in the maxilla. So we don't need 15 millimeter implants anymore. Like I said before, the socket preservation was done alio loco in another clinic 4 months ago, and with allogenic bone. And there are studies from SPIN-NATO 2013 that show that the remodeling and the development of new bone may be limited, and a scientific proof that we get a biological incorporation of the allogenic material is still missing. But I think it's depends on the philosophy. I have a lot of colleagues who are working a lot with allogenic bone. Depends on each experiences. Okay, it was a very anxious patient. I met her in advance, and I think you can see that due to the short Operation time, she is very relaxed. It's not a big thing to her. She seems to be okay. So Xive is a very, very good system. Me, myself, I also like to work with this system. It has a good primary stability in each bone quality. It's atraumatic and gentle in hard bone of density D1 and stable and secure in soft bone. Like density D4. But when we have not enough torque, we should not take a risk like we did here in this case, and do better a submerged healing. Instead of immediate loading. Okay, it seems like my colleague Dr. Werling has finished suturing. So he's changing the gloves. And please keep in mind, if you have any questions, please write us via email or on Facebook or on live stream chat. Really? We will answer some questions after this operation, and all other questions we couldn't answer immediately after the operation now live, we will answer later via email. So we will switch now to the laser. The patient gets some fancy glasses.
Siehst du das? Alles? Ja. Kann ich?
Okay, now you see the laser. We have different mechanisms. We can either use it for cutting with 445 nanometer or for gingivectomy. So when we are using this mode, we have 2 watt. It's the blue diode we are using for this diode. But now we are using the soft laser treatment, and it is 660 nanometer now. In contrary to the blue diode, which has 2 watt, this is 25 milliwatt, so less powerful. It's not for cutting anymore. It's for biostimulation. It has an antibacterial effect and gives a better wound healing. So the diode is used to reduce the bacterial levels And the result is, it gives a better long-term prognosis. It's also used in periodontology and endodontics. And the time you're using this soft laser on average is 120 seconds around. I will give you a little information to the other mode while my colleague is using the soft laser. So with the blue diode, the absorption of the blue laser light in soft tissue is significantly higher than the infrared laser. This means the laser beam penetrates tissue less deeply, and thereby it is reducing the risk of accidental injuries. So we have less heat. So the cutting mode is used for, like it said, cutting and for hemostasis. So when you have lots of bleeding, but you should never be in contact with the bone when you're using the blue diode. But what you're using here is the soft laser treatment with the 660 nanometer and less power than the blue diode. So here only 25 milliwatt to get again improved bacterial reduction, less post-operative pain and scar-free wound healing. So still using the soft laser for biostimulation. So if you need any further information about the Zero Laser Blue, which we are using here, you can find this on the Sirona homepage. And again, the Zero Laser Blue has different modes. Either bacterial reduction with the soft laser or cutting mode with the blue diode. Okay, the operation is done. Great job to my colleague. And we will do some X-ray now. And I will come back to my colleague. So. Okay, be careful. Okay, we are still not on the picture, but I'm already back in the operation room. Maybe we can just start with the questions, or I have first some questions. So how was it for you, Gerhard?
Yeah, it was routine as every time when you do guided surgery, yes.
Okay, yeah, it was very fast and
Yeah.
also the patient felt very well. So was it an easy surgery for you?
Yeah, probably it was an easy surgery, but not because I don't know what augmentation was done, because this was not an augmentation that we have done. And I recognized, as you could see, that the primer stability from the 4.5 implant was not so that I would prefer to make a gingiva or something like this. So I decided to close it here.
Yeah. So I commented this already.
Yes. Okay.
Because we were talking about this in advance, that the bone augmentation, or let's say the socket preservation, was done alio loco at another clinic.
Okay.
And you never know what osseointegration you will find. It also depends on the regeneration potential on the patient, right?
Yes.
So, and here we had not enough primary stability.
Yeah, in 3.8, sure, we had near to 50 Newton centimeters.
Okay.
But on 4.5, it only got up to 20 Newton centimeters, and this is not enough to go on directly in the surgery.
Okay, okay. So, what are the next steps for the patient?
So we have to wait until the implant osteointegration is finished. I think we will wait another 4 months, maybe 6 months, because the distal implant of the 4.5 is only an augmentation material seated, I think. So it's better to wait a little bit more.
Okay. So, right now I'm getting the questions of our colleagues and viewers on the stream, on the live stream. Thank you very much for this. I will read some of the questions. We have many questions, but we will start with the first few. So, what was the biggest challenge during this surgery?
Yeah, I mean, the biggest challenge is to do it live. You always get a little bit nervous when you do it live, okay? Because you think someone is watching at your fingers. So, but and as we are working on it, it's still the same than we have ever. You know? So it was not such a big challenge. Only to know what bone we will find, and that's the point in this case.
Okay, okay. So another question is here: why did you decide to use guided surgery?
Yeah, because the preciseness that I find with this system, and to get the, even if you do your planning from the implants in cone beam and then superimpose the model, you do a little bit of correction when you make backward planning. And so you could achieve better results when you do it guided. And the costs are not so big. So I say to every patient, please decide if you want to have it guided or conventional treated. And everyone say, no, I think I want to have it guided.
Okay, and we have like I said before, we have a reduced operation time. Maybe we spend a little bit more time for planning, but reduced operation time, and that means also a better result or better healing for the patient.
Yeah.
Another question is, do you always use the digital workflow for implantology? If yes, why?
So that means if you use always CEREC or if you use a cone beam, I would say definitely to both yes. Because I get my backward planning inked out from CEREC, and I have a perfect view into the bone when I do my cone beam. So we don't make any implant without 3D diagnostic. Definitely.
Okay. So another question, what are the benefits of a digital impression, Omnicam versus conventional impression?
So if you do conventional impression, you have your models, for sure, you have to store the models. And here it's very comfortable for the patient. You just open his mouse and you go through with your Omnicam and you get the pictures right away on your screen and can work with it. So it's for everyone a better workflow.
Okay.
And as you could see, we all delegate this to our assistants. So it's not the job from the dentist anymore. It's coming more and more that you have special assistants for the CEREC job, I say.
That's always good when you have the possibility to delegate things, and because in this time you can do other things, for example.
For sure.
Okay, that's good. So why especially in this operation you were choosing Xive implants?
Yeah. Xive implants, we do a lot of different systems in our practice. But so you can choose what will be the best for this case. And I thought, as I saw the augmentation from the bone, that and we do use short implants because she don't want us to do any sinus elevation or something like this. She said, don't touch my sinus. I want only implants in the bone that is already there. And so I decided I want a great primer stability. And primer stability means, in my opinion, is I have a good experience with the Xive system. We're using this now for about 10 years, and it really looks great.
Okay, I am just listening from the regisseur that we missed the first part of the answer. So once again, why Xive system?
The Xive system has a really, really big, great primer stability from the system that I'm using. So we see here the result. And I think it's definitely the same that we had in the planning. Yeah?
Yes, definitely.
Yeah. So everyone is happy. We wait until another 4 months. It's not so many time. If you see, she's only 34 years old. 3 months or 4 months are nothing. And then we go on with a digital workflow. That means we open this and then we make our scan with the CEREC system, with the scan post and all, and then we make a screwed through crown in this case.
Okay. Okay. The question, I just got another question.
Yeah.
Why did you open the tissue?
Why did I open the tissue? So, because we saw in the cone beam that there is maybe a bone edge, and I want to reduce this bone edge if this would be there. And the other part is, if we make it with healing abutments or something like this, I want to handle my gingiva. I could handle my gingiva better. Okay. That's the point in this.
And also, anyway, you avoided to do relieving incisions, right?
Yes.
So to keep the blood supply, obviously.
Yeah, that's what we learned in all the beautiful lecture that we see all over the world. Yeah.
Okay, I just got another. I think it's one of the last questions.
Yeah.
If we are using mini implants, or if you are using mini implants, what do you think about that?
Yeah, as we started in implantology in 1992, it was 50 millimeters, 4.5, 5.5, and 6.5. So if you have done this time implant who's only 8 millimeters and 3.4, it will kill you. But now we see the studies and everything, as you know, that this will work. So I think it's not a problem to take a 9.5 and don't make a sinus elevation in this case. Because we talked, we were a little bit anxious, the patients, and we talked about this. And she said, I want a shorter implant, 9.5 isn't this short because it's a diameter from 4.5. So, and she's going to say to me, if I'm going to lose it, then you can do also the sinus flow elevation. That's what she told me. Okay.
Okay. Okay. Okay, good. So in this case, you could avoid a bigger surgery by planning it to do this backward planning?
Definitely, because you see it as a three-dimensional way, everything. You see exactly if there's enough space for the implant.
So when I see this picture, it's really great because it's exactly like you planned it in advance.
Yes.
And I think it was a perfect operation. Congratulations to this.
Thank you very much. I would say it's a little bit daily routine if you're using this.
Okay, that's true. Yeah.
I know, Frank, you also have to do this in future.
Definitely. So, to our audience, to the colleagues and gentlemen and ladies who watched us, thank you very much for watching us. If you have any, so we tried to answer some of the questions, but we couldn't answer all. If you have any more questions, please write it or write us in Facebook or in the live stream chat, or to our email address, which is livestream@dentsplySirona.com. And once again, thanks for watching us, and I think it was a great job what you did. Congratulations to this.
Thank you very much again, Frank. And don't forget, we have done a lot of video around this case, and we will bring you the follow-up, all the pictures, and what we are doing with the CEREC machine when the 4 months are done. And you will find this also on the Sirona YouTube channel or in Facebook. Thank you very much also from my side for watching this.
Okay, bye.